So welcome everyone to our fourth SMM webinar, and we are going to go ahead and get started. This is just a brief overview of our agenda today. And then if everyone wouldn't care, we are going to do a Mentimeter during the first portion of the webinar. So if you don't care to scan that QR code, and then also let me grab
I can put the link in the chat if you want me to.
That's what I need, Anastasia. Thank you. Just so that we can go ahead and have that ready. Okay. And hopefully everyone has had time to scan that. If not, then Anastasia is going to put it in the chat for us as well. Okay. And our speaker today is Dr. Connie Graves. She is going to be doing a focus on pregnancy-induced spontaneous coronary artery dissection today as part of our fourth series of the SMM webinar. Let's see, Dr. Graves.
Well, good afternoon, everyone. Hope everyone's doing well in Nashville. I hear it's raining. I'm here at sunny Hilton Head, and actually I had to run out of my conference's question and answer session. And I'm just so glad to see that everyone is here. The first part of this, I'm going to review a little bit about what SMM is, why our data is important, and then I'm going to talk a little bit about the difference between morbidity and mortality, because your top causes of morbidity may not be your top cause of mortality. And that's really something we have to hopefully we'll be able to understand. Next slide. So this is our report. It was from the state of Tennessee. It was published in April 2025 and encompassed the years from 2018 to 2022. So when we talk about the spectrum of severe maternal morbidity, this results from unexpected outcomes of labor and delivery, such as hemorrhage, organ failure, and stroke that lead to short and long-term consequences to a woman's health. So when we talk about, we often review maternal mortality cases, but maternal mortality is really the top of the pinnacle. It is the last thing that happens. So this is why doing this type of conference or looking at these things is so important. The next down would be the maternal near miss. For example, we have those patients who come in who are bleeding or who may have a seizure of some type, and they end up being in the ICU for quite some time. And we think those patients may or may not make it through, but they do, and that's a near miss. Then there's severe maternal morbidity, which really is what we've been collecting before we get to near misses and before we get to maternal death. Those are the things that we're going to be talking about today and how to look at it differently. And then maternal morbidity, and as we've been talking about here in our high-risk conference, not just morbidity that is physical in nature, but also some of the harm that we can do by not providing the best of care. That's why it's so important to think about how we as a team can provide the best of care, both for the physical outcome and the emotional outcome. And then there are pregnancies that we quote call uncomplicated. Although as a maternal fetal medicine specialist, I would pretend that those pregnancies may be uncomplicated, or that delivery may be uncomplicated, because we spend a lot of time on the front end in the antepartum period making sure that is an uncomplicated delivery. Next slide. So these are indicators of a severe maternal morbidity and mortality. In the cardiac realm, acute MI, heart failure during a procedure, an aneurysm, cardiac arrest, which is the ultimate pulmonary edema, and then, of course, conversion of a heart rhythm. In the hemorrhagic side, which we know in Tennessee can be an issue for us, DIC, shock, and then, of course, a hysterectomy. Acute renal failure, which may result from especially 1 and 2. Respiratory complications such as acute respiratory syndrome, the need for mechanical ventilation, sepsis, which often can cause especially renal injury, other medical diseases such as cerebral vascular disorders, stroke in particular, and sickle cell crisis, and then other obstetrical complications such as an air or thrombotic embolism, such as a pulmonary embolism, an AFE, preeclampsia, and then severe anesthesia complications. So these are all the things that make up severe maternal morbidity. Patient doesn't die, but may progress to a near death event. Next slide. So what are some of the findings? And we had in the state of Tennessee, for every 15 deliveries, there was a severe maternal morbidity. And now I don't think anyone is surprised by that because Tennessee leads the nation in maternal mortality. So what that means is that every time we deliver a patient, every 15, we have an issue. Now, I think about that in terms of where I deliver mostly, but at the two hospitals I deliver at together probably deliver about 10,000 patients a year. Think about that. If there's every 15 deliveries, think about how many patients are affected. That's over almost 1,000 patients will have some type of severe maternal morbidity. In addition to that, during COVID, there was a 23% increase in morbidity, keeping in mind that COVID not only caused respiratory complications, but also disseminated intravascular coagulation issues, preeclampsia and eclampsia, and was associated with the increased risk of VTE. Hemorrhage diagnosis and procedures are one of the most common, accounting for a third of morbidities, many of them associated with cesarean section. DIC, not uncommon, because of the fact that if you hemorrhage and you rapidly or you can't replace it quick enough, that's going to be an issue. Hysterectomy as the final kind of thing, or the final treatment for hemorrhage. Of note, non-Hispanic Black women also had the higher burden of severe maternal morbidity. It was also higher in women over 40. So when we talk about regional rates of populations that have issues, keep in mind that women over 40 are at significant risk for issues. Then there's severe maternal morbidity across the state, which was highest in the East and West, and then kind of over toward the East in Knox and Madison County. If you lived in Upper Cumberland, you have the lowest rates. Next slide. Again, here's the distribution. You can see hemorrhage is the largest part, followed by respiratory, other obstetric, renal, cardiac, then sepsis, then other medical. Next slide. And as I pointed out, morbidity was significant, almost twice as high among non-Hispanic Black women in the state of Tennessee versus non-Hispanic white women and Hispanic women. Next slide. Now, keep in mind that the average timing of these deaths, most of them do not occur during the day of the delivery. Only 10%, and probably most of those were associated with hemorrhage. 19% occurred during the pregnancy, but 71% of our deaths are after delivery, which means that many of these women have severe maternal morbidity and complications that are resulting in prolonged hospital stays. And if you think about it, some of the deaths are actually the culmination of the events that may have occurred on the day of delivery, but then progressed. But I want to point out something. While hemorrhage is the leading cause of death and our leading severe maternal morbidity, cardiovascular, which is only 10%, is our next cause. So 37% of deaths in the state of Tennessee are due to cardiovascular conditions, then followed by sepsis, which is right under cardiovascular. That's why I wanted to really point out that severe maternal morbidity does not always, it may be an indicator, but does not always lead to severe maternal mortality. Next slide. So let's get into our case for today. And I'm going to tell you, I made the case to protect the innocent. I put a couple of cases together. Now, I don't know if it's just me, but I think when I'm on call, there's a whole lot of things, a lot of stuff is going on. But one of the things we noticed in our maternal mortality review board is that we kept on having women who presented with certain factors, but the diagnosis was not made. So I'm hoping in this webinar that I'm going to raise your awareness of pregnancy-induced and spontaneous coronary artery dissection. Of note, I've had I had 2 patients last year. The year, and one of my now attendings, one of my former residents, presented one at our Society of Maternal Fetal Medicine. So spontaneous coronary artery dissection, while rare, is something that we really need to be cognizant of and how to manage it so that we can take better care of our cardiac patients. Next slide. So I'm going to discuss the presentation of coronary artery dissection SCAD in relationship to pregnancy and postpartum. Discuss what the risk factors are. And really, I want you to have some tools, some understanding to recognize and manage patients who present with SCAD. Next slide. I have no financial disclosures. Next. So here's our case. This is a 41-year-old gravid 1 para 0101 who presents 5 days postpartum with complaints of intermittent chest pain. She reports her pregnancy was complicated by severe preeclampsia with required delivery at 28 weeks gestation. She endorses palpitations and some mild dizziness when the chest pain occurs, but tonight states the pain lasted a little longer. That's why she came in, but right now she feels fine. Okay. Think about the case presentation. Next slide. Here's your first question. So, what is your plan of care for this patient? You're going to order routine labs and place the patient on telemetry. Call all of cardiology because you don't do hearts. Order labs, biomarkers, and an EKG immediately. Observe the patient on telemetry, and if it's okay, send the patient home.
You can hear their hands.
Have 19, is that right, Tanika? Only 4 people have voted.
Yeah,
So far.
4 out of the 19 people we have logged in.
All right, you got to cast your vote.
Mhm.
If you don't vote, you get what you asked for.
And also the link to the Mentimeters in the chat too, where you all can scan that QR code in the bottom left-hand corner.
I give everybody a few more minutes to get it loaded for you. All right. So most people think that it's number 1. A few people would just order routine labs and place the patient on telemetry. No one wanted to send the patient home. That's good. And so we're going to order our labs, cardiac biomarkers, and get an EKG immediately. Okay, next slide. You decide on answer C, and your results are as follows. Your white count is 15,000, hemoglobin 11.1, hematocrit 37, platelets 300. Your troponin is 70 nanograms per milliliter, and your BNP is 200. Okay, those are your labs. How many people are happy with these labs? You can just raise your hand. How many people are unhappy with these labs? You can react. All right. Everybody, no one's happy with these labs. Next slide. So the patient reports her chest pain is increased and she is now short of breath. Her EKG is as follows. Now, people always are telling me that they want normal EKG, but I think that most people can see this EKG is abnormal, and there's elevation of your ST segments, which denotes that the patient has decreased oxygen to her myocardium. Next slide. So this is your next step is in the patient's care. Repeat the labs, including a troponin, start crying, transfer the patient immediately to cardiology, place oxygen, and call for rapid response. All right, we got some votes here. People are still coming in. So your troponin is already elevated, and now your ECG shows that you have myocardial ischemia. So the first thing you want to do is place oxygen and call for rapid response. If you'd like to start crying, that's okay, as long as you place your oxygen and call for rapid response. So that is the next thing you want to do. Now, you can repeat your troponin, well, but your EKG at this point in time has given you your answer. Okay, next slide. Very good. The rapid response team moves the patient quickly to the coronary care unit with a diagnosis of acute MI. She is placed on heparin as the communication of the patient's post-delivery status was not communicated to the team. After 18 hours, her chest pain persists, and the patient then undergoes cardiac catheterization. Next slide. You can see this is your left coronary artery here, nice and big, and you can see here that through this smaller vessel that looks like a little lumen, like it doesn't continue, and there's ballooning outside of after that. So during the catheterization, the patient is diagnosed with a spontaneous coronary artery dissection. Next slide. So catheterization demonstrates a type 2 dissection. We're going to talk about that. The patient continues to have intermittent chest pain despite treatment. Your repeat labs are a highly sensitive troponin of 154. It's almost doubled, and a BNP of 170. Okay. This is where we are. We know that the patient has a dissection, and now our labs are increased again. Next slide. Okay. This is question 3. Your next step in the care of this patient is to continue observation, contact cardiology for next steps, obtain a stat EKG, ignore as the patients with SCAD may have recurrent chest pain. Okay, very good. While it's important, it's very important to obtain a stat ECG. At this point, you have you want to also make sure that your patient is stable. So you're going to contact cardiology for next steps. While you're contacting them, you want to obtain your data, because we know that your troponin has increased again. So you want to make sure that you obtain that while you're talking to them. You want to continue. You don't want to continue to observe, because while patients with spontaneous coronary artery dissection may have recurrent chest pain, each time they have it, you want to get another EKG. And of course, we're not going to ignore the patient. So so either one or two would be correct. I would probably order my stat ECG and then call cardiology to let them know what's going on. Next slide. So here's your ECG. You can see that despite the fact we went to the cath lab, that now we have even more ST elevation, and we have a little bit of tachycardia. Anybody happy with this EKG or ECG? No one is happy. You can read. Okay. Excellent. Next slide. The patient reports her chest pain is even worse than prior to her catheterization. The team decides to contact interventional cardiology for repeat evaluation. Cardiac surgery is placed on standby. After consultation, the team decides to repeat the catheterization to see if the patient has extended her SCAD, or if we have iatrogenically extended the patient's SCAD during the catheterization. Next slide. During the preparation for the procedure, the following rhythm is noted. Anybody like this rhythm? Yeah, this is ventricular tachycardia. This is a non-perfusing rhythm, and if it's allowed to go untreated, it can get you into big trouble. Next slide. It's our last question. Given the current rhythm, you would, number one, call the coroner, get a code, call a code, get a crash cart, I'm sorry, not crash cart, and prepare to shock the patient, immediately move to the OR, leave the room and call for help. So the one thing, anytime you have an unstable patient, you don't want to transfer them, you want to stabilize them. So the people who voted for call a code, get the crash cart, and prepare to shock the patient to get them out of the rhythm to stabilize them would be the most appropriate. Very good. Next slide. The patient is successfully stabilized, transferred to the OR for immediate coronary bypass. She has a 3-vessel bypass, which is successful. She is discharged on postpartum or post-op day number 15, postpartum day number 15, post-op day number 5. And her genetic testing in the postpartum period was unremarkable. Okay. So you guys saved the patient. So spontaneous coronary artery dissection is a rare cause of heart attack in young, healthy women that's not associated with traditional risk factors like atherosclerosis. So this is why it's so important. And I'm going to show you where there was an error in this patient's care, that when a patient comes into the ED within the first year of pregnancy and during pregnancy and postpartum, that is conveyed to the team that the patient is pregnant or postpartum. Because we're going to talk about what in this particular case. Next slide. So it's causes about 1 to 4% of cases, although it is the most common reason for pregnant or postpartum women to present with myocardial ischemia. About a fourth of the cases are women, and it can be more aggressive than non-pregnant associated SCAD with a higher risk of cardiogenic shock, arrhythmias, and ventricular fibrillation, as in this case. Next slide. Well, let's see when patients are more likely to get SCAD. First trimester, a few. Rudely, some of them do it in the third trimester. That was the case that we presented at the Society of Maternal Fetal Medicine. At delivery, but most spontaneous coronary artery dissections occur, as in this case, within the 1 month and the first 4 weeks postpartum. Look, week 2, 10 days out, is the highest time for this particular phenomenon to occur. Week 3, week 4, much less. And keep in mind that pregnancy lasts, or the effects on the heart can last up to 6 months. And so after about 6 months, notice that you see that the incidence of SCAD goes down. Next slide. Well, patients who present with pregnancy-associated SCAD usually present with signs and symptoms characteristic of an acute MI. Chest pain, arm pain, neck pain, nausea or vomiting, sweating or diaphoresis, shortness of breath, and back pain. Now, because of pregnancy-associated SCAD, life-threatening ventricular arrhythmias that occurred in this case can occur to 4 to 14%. But also one of the clinical features in presentation was something in this case as well. Remember, when the patient got to the ED, she said she felt better. So we have seen patients who present with this particular disease process, actually, they say, oh, she's feeling better, and they send her home because no one drew cardiac biomarkers, so there was no denotation that that was elevated. So anytime someone has chest pain, especially in the postpartum period, you need to advocate for the patient having appropriate cardiac labs drawn. Next slide. Well, what causes pregnancy? Hormonal changes of pregnancy that we're going to talk about seem to increase the risk of spontaneous coronary artery dissection, fibromuscular dysplasia, multiparity greater than 4 births, connective tissue disorders such as lupus, Ehlers-Danlos syndrome, things that can cause dilated aortic roots, things of that nature. Marfan syndrome can increase the risk. Systemic inflammatory conditions. One of my patients who had one of these, she's part of the whole scheme, was visiting her 23 and 5/7 week baby in the NICU when she decided to spontaneously dissect her coronary artery. Fortunately, our nurse practitioner was on it, and she picked it up immediately. However, later on, the patient tested positive for lupus anticoagulant and an systemic inflammatory condition, and her anti-cardiolipin was almost 200, many times out. And then last but not least, as in this case, preeclampsia and hypertensive disorders of pregnancy. These are so interrelated. Next slide. Well, what is the pathology and the pathophysiology? There's a tear of the vessel, and that it's between the outside and the inside of the vessel, like the lining of the vessel and the outside covering of the vessel. So it creates this kind of false lumen, and then it becomes filled with blood and it clots off, and that's what causes the issue. Pressure-driven expansion of the false lumen may enlarge the hematoma, and so if the patient has high blood pressure or if she is tachycardic, this may actually result in further damage, and it is also can result in, on the other hand, this extensive dissection, as I talked about, can come from pre-existing things, genetic issues, aorthopathies that increase the patient's susceptibility. Next slide. So in pregnancy and early postpartum, dissection may be a consequence of the physiologic and hemodynamic stresses, or that the hormones may actually cause weakening of the coronary artery. The intramural hematoma usually involves 2/3 of the inside of that vessel. And again, there's some inflammation to come break down the clot. And there may be some other fibromuscular issues that predispose patients to this type of myocardial infarction. Next slide. So the left anterior descending coronary was most frequently seen, which is not that great because that's what supplies your heart. And the most common type is type 2. I said, well, Dr. Graves, you've been talking about these types. What do they look like? Next slide. We're going to be talking, the diagnosis again is as looking on angiography, or basically diagnosis by exclusion. And so we know that most PSCAD presents as type 2. And because it presents as type 2, it's long and luminal, occasionally what will happen is often missed, even when angiography is performed. Next slide. So just remember the hemodynamic adaptations. Cardiac output, and we talked about this before, increases 30 to 50% with an additional 15% for twins. Plateaus at 24 weeks, increases 30 to 40% during labor, increases again in the postpartum period due to autotransfusion, and as I pointed out, doesn't return to normal to 3 to 6 months. Next slide. And I love this graphic because it shows you in the immediate postpartum period with autotransfusion, you can see that cardiac output can increase as high as 80%. This is why many of these women present in the postpartum period when cardiac output begins to go up significantly. Next slide. Blood volume also increases, putting pressure on your vessels. And keep in mind that all these patients are functionally anemic because their red blood cell volume doesn't increase as much as their plasma volume. It returns to normal somewhere in the postpartum period, about 8 weeks out. But there's also an increase in coagulation factors. So if you have something like this, the clot is more likely to form. Next slide. And this is just a graphic from just to remind us that it takes 3 to 6 months for the cardiac output to return to pre-pregnancy values. Heart rate, blood pressure may take up to 3 to 6 months. That's why I tell my patients when they're on blood pressure medication, it may take a while for your blood pressure to come down. And during early postpartum, there may be as much as a half a liter due to autotransfusion. And these also take 3 to 6 months to return to normal. Next slide. Just remember on your, there's changes in your cardiovascular testing on your EKG. Your mean QRS is shifted to the left. There are minor S to T to T wave changes, Q waves in your, and with your T wave inverted and leaves 3 at AVF. This is what gives you that reading that says anterior MI of unknown significance. However, ST elevation is never normal in pregnancy. And ST elevation, you can easily see is that segment above the baseline. It's also not uncommon to have occasional skip beats and some supraventricular tachycardia. But in this case, ventricular tachycardia is abnormal. Next slide. And just to remind you that your echo can show left ventricular shortening, but it should not show reduced left ventricular ejection fraction. And in case, it should actually show an increased one. Small pericardial effusions are not uncommon from echo. And usually there can be myovalvular regurgitation, but if you get aortic regurgitation of any significance or insufficiency, that is pathologic. Next slide. So let's talk about types of Type 1, you can see it because there's a double on each side, a lumen. This is the one that's less likely to be missed. Type 2, there is a reliance on, there's multiple lumens or there's narrowing. And like I said, this can be missed in almost half the diagnoses. And the other one, type 3, which is pretty rare, there's like a tubular stenosis, but there's no sign of the patient has calcium deposits or things of that nature. Next slide. So I just bring this up. You can see this is a type 1. You can easily see it. There's this translucent flap that you're going to be able to see on echo when you're looking at it here. Type 2, you kind of get this double lumen that looks like diffuse narrowing. It can be missed. And then there's type 2B, which kind of goes down to this distal tip of the coronary artery. And then type 3, which sometimes looks more like a like a vascular constriction, which is a focal stenosis. Next slide. At the time of presentation, the patient is more likely to have a non-STEMI or a STEMI type 1. Occasionally, they will have cardiac symptoms. Usually, there are multiple, SCAD is multi-segmented. The proximal vessel being a little more likely to be affected than the mid or the distal vessel. And for the most part, as we're going to talk about for management, intervention is conservative. We don't have to do anything. We establish the diagnosis and we watch the patient. However, some patients will require stenting, more likely for some levels of SCAD. And then occasionally patients will require coronary artery bypass, as in this particular case. Next slide. So again, here's that central illustration. You can see why type 2 is more likely to be misdiagnosed, because it looks like the lumen is still open here. But I want you to look at all the things that can increase your risk of SCAD. Emotional distress, well, having a baby can definitely do that. Valsalva and straining, well, we just got finished pushing. Intense exercise, sex hormones. And then we combine it with our genetics, hypertension, pregnancy, fibromuscular dysplasia, and those are aorthopathies we were talking about, such as Marfan's and Ehlers-Danlos, connective tissue disorders, and migraines. Patients with migraines have vascular reactivity and are at increased risk for having an issue with cardiovascular reactivity as well. Next slide. So how do we manage this? The first thing we're going to do is we're going to try conservative management. Medications, including beta blockers and aspirin, to reduce the myocardial stress and to assist with healing. Keep in mind that beta blockers slow your cardiac rate and they improve the oxygen consumption of the heart. We also want to consider dual platelet therapy, such as Plavix, to actually reduce the risk of clotting, so that the area of the intimal damage can heal and the clot can resolve. Now, in the old days, we used to start people on statins, but they're only indicated if the patients have elevated lipids. Now, anticoagulation is contraindicated. Does anybody remember to the beginning of our story? What happened with the patient? She was started on heparin and monitored in the ICU because they thought she had a heart attack. This is why the history of being pregnancy and postpartum is so important, because in this case, heparin should have never been started. The patient should have been immediately taken to the cath lab to establish the diagnosis. And the question always becomes, because we started, did we extend? We won't know. If the patient is pregnant, this is not the time to consider doing an emergency C-section if she's not unstable. And in fact, you want to consider allowing the heart to heal 2 to 4 weeks if possible. And we'll talk about the mode of delivery. Cesarean section, in the emergent cesarean section, should only be considered during or immediately after. It should be considered only considered during or immediately after the patient is stable, if the patient can't be hemodynamically stabilized. This type of delivery, an emergency cesarean section, is for that VTAC. If we had not been able to get the VTAC and that patient had been pregnant back in line, if we had not been able to stabilize that patient, then we would go to our cardiac arrest and our postmortem C-section protocols. But just because the patient has had a SCAD doesn't mean you just schedule her for delivery tomorrow. And in the patient that I talked about that was pregnant, I actually had to almost throw myself over the patient. And she was 35 weeks when she dissected, and we delivered her at 39 weeks. So these patients do not need to have an immediate delivery, and that should not be part of your plan unless they're unstable. Next slide. So we talked about the conservative management being preferred. Most of these lesions will heal spontaneously if the patient is stable and she has no other ongoing ischemia or severe left main or proximal disease. I will tell you that most of the SCADs I've taken care of, this was the first one I've ever had to bypass. Most of them, we just sent them home, they came back, everything was fine. Cardiology followed up, patient did well. Next slide. Now, you can stent the patient percutaneous cardiac intervention if we feel like that there's ongoing ischemia and there's large territory involvement, or if there's a left main dissection or the patient has failed conservative therapy. However, as I talked about, there's a higher risk of actually making your dissection progress. And if they're pregnant, we have to do that under radiation. And although we know that radiation should never preclude the patient from appropriate care, if we can shield the patient and do an approach that is above the abdomen, it makes it less likely for the baby to be exposed. Next slide. Now, you want to consider a coronary artery bypassing when the patient is unstable, or in this case, when the patient had VTAC and cardiogenic shock. Next slide. So what are the delivery recommendations? We've already talked about cesarean section is only for obstetrical indications. Vaginal delivery is preferred. Epidural anesthesia. Epidural is the bomb for reducing stress responses. I like all of my patients to have them who have cardiac disease or anybody who I'm really worried about controlling their heart rate. You want to do this with a multidisciplinary team with MFM, cardiology, OB, and anesthesia. If you're doing it and she's had the SCAD prior to delivery, you want to monitor blood pressure closely and avoid hypotension and hypertension in labor. You want to avoid increasing the heart rate, as we talked about, because that may increase the risk of poor oxygen delivery to the heart. Telemetry in labor, and you want to consider an assisted second stage for persistent tachycardia. You don't want the patient to push down. You want her to use open glottis pushing and not do Valsalva, because Valsalva does increase your risk. Next slide. Well, what about your postpartum considerations? Breastfeeding and lactation should be undertaken with shared decision making. So Esther Kim, who is an expert in SCAD, who used to be at Vanderbilt, did not really recommend breastfeeding in some of her patients because there was some animal data that oxytocin itself causes laxity of the vessel and may extend the SCAD. However, that data has not proven to be as applicable to us and to women and to birthing persons, and so therefore currently the current thought is that the cardiovascular benefits may outweigh the slight increase of recurrent dissection. But again, the patient does need to know that there is data that may suggest that breastfeeding possibly could increase their risk of having an extension or recurrence. Remember that the postpartum period we saw from the SMM is a high-risk period, and you want a management of hypertension is imperative. Management of hypertension is imperative. Next slide. So as my patients, they're going to come and say, well, Dr. Graves, I need to have another baby. So remember that patient I told you that had the pregnancy SCAD, the one at 35 weeks that I had to stop them from sectioning. Well, 2 years later, she, being a healthcare provider, she took out her own IED and came back pregnant again. So what do you tell the patient? Well, preferably, I would like to see her preconception. But anyway, the recurrence risk is uncertain, but may be higher than in patients who've not ever had spontaneous but probably higher than non-pregnant patients. And it may be higher, it is higher than in than patients who have not experienced SCAD prior. However, there are now several case studies and case reports of women who've had babies after SCAD, including mine, who have made it through without difficulty. You need to have the patient have shared decision-making with cardiology and maternal fetal medicine. You want to avoid pregnancy if there's persistent cardiac dysfunction. Preconception counseling with genetic testing. I have listened to so many women that say we don't do adequate genetic testing, non-hormonal contraception with an IUD, and if pregnancy is desired, you want them to have close follow-up in the antenatal period. Next slide. So what are the activities after SCAD? Because patients are going to be nervous. We want them to join a cardiac rehabilitation program. We want them to have a multidisciplinary approach. They need psychological counseling, often in dietary, nutrition, peer support groups. And I have found, since I've taken care of 5 of these women, connecting them with each other is very important. You really want them to not, one of my patients was a yoga instructor, actually. And she wanted to know when she could go back to yoga, but you really want them to keep their heart rate on about 50 to 70% to their reserve and maintain their blood pressure less than 130 over systolic. So yes, they can have exercise, but it really needs to be done in conjunction with a rehab program. And for your patients who are active, I normally make sure that they get connected. And then you want people to reduce their life stressors, because we do know that stress can increase the risk. Next slide. So in conclusion, pregnancy-induced SCAD, while rare, is the most common cause of acute MI in pregnancy and postpartum. There should be a high index of suspicion, is required to recognize it when the patient presents in the pregnancy and postpartum period. Why it's so important for people to know that patients are pregnant or have been pregnant within that year. Multidisciplinary care is required to ensure a good outcome in these patients. Preconception and inter-pregnancy care should be standard for this population. And I want to stress over and over again the need for referral for genetic testing for aortopathies. One of the things that struck me the most when I've been working with the National Academy of Sciences on cardiac conditions, is that women talk about that no one talked to them about the underlying genetic risk. And then shared decision-making is required to evaluate the risk-benefit ratio of future pregnancies, whether or not they're going to breastfeed, and of course, for all of our patients who have an adverse pregnancy outcome, counseling regarding contraception. I so appreciate your attention. I want to leave a few minutes to chat in for questions or discuss any or anybody who's experienced SCAD in their hospitals to discuss. So I thank you for your attention, and I will be happy to take any questions that you have.
Right. Looks like Chrissy, do you have a question?
No, ma'am, wrong button.
I don't see any questions just yet, Dr. Graves, but everyone thinks that it was great information, a great presentation, and I completely agree with them. I thought that it was fabulous.
I think the most important thing is to raise awareness, because we're the caretakers of our patients. We are women's healthcare providers. And if we don't champion and we're not out there saying, hey, I understand you think this is an acute MI, but she is 7 days postpartum Have you, I know that you're the cardiologist, but have you heard of pregnancy-induced spontaneous coronary artery dissection? Should we call someone who may have more experience? When Esther Kim was at Vanderbilt, I was always, I had 3 of these patients, I think, when she was there. And every time I had one, I would call and just run it by her. And now that she's in North Carolina, the most recent patient that I had who ended up with the coronary artery bypass, I actually called her, said, can I ask you a few questions? And then I went back to the cardiologist and said, hey, I talked to Dr. Kim, and these are some of the things that she recommends. So it is so important for us to advocate for our patients, because this particular disease process is related to pregnancy and the postpartum period.
Well, thank you again, Dr. Graves. If anyone has any questions, just go ahead and put them in the chat. Kathy, yes, this presentation will be available. We will post it on our website under initiatives, and then go down to SMM, and we have all of our previous webinars there, as well as some resources for you all.
And Michelle, thank you for sharing. Michelle wrote in that she actually had a spontaneous coronary artery dissection almost 1 year postpartum with her last child.
We will just end with just a few quick announcements then, if no one has any questions. We have more webinars upcoming. If you all would want to register for those, if you just scan that QR code down at the bottom or go to tipqc.org and look for events. And then I'm also going to add it to the chat as well. So we hope that you're able to join us for a few more of these. And we have our next SMM webinar scheduled for January 14th. And then save the date for our annual meeting, March 24th through the 26th. The 24th is in the evening portion. That's when that will be starting. And it will be in Franklin, Tennessee at the Cool Springs Marriott at the normal place we usually hold it at. And then if you all just wouldn't care to take a moment to do our post-event survey, let us know what you thought about today's presentation. And also you could chat in some categories that you would like to have in future presentations for physicians to share on that they've seen. And of course, just a special thanks to our partners. And we so appreciate you all being with us today for our Lunch and Learn, and we hope that you were able to enjoy some lunch.
Thanks so much, everybody. Happy Thanksgiving. Thank you, Dr. Graves.
Thank you, guys. Thank you for taking time out.